Good afternoon. It's 1:10, and it's time for this year's ACTA lecture at the Swedish Surgical Week 2024. My name is Andreas Moth. I'm the Scientific Secretary of the Swedish Surgical Society. First, I would like to start off with a few words about the ACTA lecture. NRK was a professor of surgery at the Maria Hospital in Stockholm, and he founded the ACTA Kirurgveckan Scandinavica in 1919. And he did that to facilitate the publication of science from Swedish and Scandinavian surgeons. And this lecture is made possible by generous grant from the ACTA Foundation, and the ACTA Kirurgveckan Scandinavica has merged and merged again, is now part of the British Journal of Surgery. Now, for this year's lecture, we have invited Professor Ville Sallinen. Ville is an adjunct professor and a consultant gastrointestinal and HPB transplant surgeon at Helsinki University Hospital. He's a true scientific surgeon. He runs a research group in Helsinki and has published extensively, even a few good papers, I hear. He has had a long-standing interest in surgical publication. He's been an assistant editor at the British Journal of Surgery. He's been editor at the BJS Open, and he's now serving as editor-in-chief of BJS Open. So Ville is a man who knows a lot about surgical publishing. So, in the spirit of NRK, we think that it's fitting to invite Ville. We thought it was fitting to invite Ville this year to talk to us about the question of how to write a scientific surgical manuscript and be published. Please welcome Professor Ville Sallinen. And I say, if there are questions, you can put them in the app, and we'll take that afterwards. If we get a few minutes, we'll see. Okay.
All right. Thank you very much for the kind introduction, and thank you very much for inviting me here to keep this prestigious ACTA lecture. I'm really honored to be here to share this with you. If you have any questions or any comments, you can just ask after the lecture. So, my topic is how to write scientific surgical manuscript and be published. And I will start just saying that if the study plan is not good enough, it is impossible to write a good manuscript. On the other hand, if the study plan is gold, you can still end up with a poor manuscript. So the goal must be something that you must have a very good study plan in the beginning and then write a very good manuscript after that. So how to be published, it's not just writing, and I have divided my lecture into 3 parts here. So pre-writing, writing, and then post-writing, and I will go through with this with you in a minute. But let's just remind us how the surgery works also. So this is Frank C. Spencer from the 40s saying that plan well, cut well, get well, pointing out that surgery is not just manual dexterity, it's just 25% according to him, and then 75% of decision making. And this kind of applies also to scientific writing. It's not just about writing, it's about decision making in pre-writing phase. So I consider the pre-writing phase as the most important phase of scientific manuscript process. So you need to have a really good study plan. It starts with a literature review. It's literature, do your own research at that point. What is known on the topic? What is the knowledge gap that needs to be filled? And most importantly, has my question already been answered, and should I be asking some other questions? The aim and question, it should be very focused, preferably just one question at a time. And the methods has to be so chosen that they will provide answers to your one question. And then always do power calculations for sample size before you start doing your study or research. And when you have done the sample size calculations, you will end up a number of patients that you will need. And then you need to be thinking that, am I able to get such an amount of patients for my study? Or do I need to, at this point, or already involve other centers, other countries maybe, to join in the study to get to that patient number? I'll provide you an example here with uncomplicated appendicitis. I think every surgeon has a feeling or a strong opinion about how to treat appendicitis and when to treat it. And the problem I'm introducing here is that, do we need to operate during the night? I think this is many residents think about this all the time when they are on call. So do your own research. What is known on the topic, this is probably the best paper, or was the best paper on the topic. This is a multi-center observative study on this topic led by Anil Bangu from UK. It had 95 centers, 2,500 patients, and it also was a meta-analysis of 11 non-randomized studies with almost 9,000 patients, so total almost over 10,000 patients. And they concluded here that delay up to 24 hours is safe, meaning that it doesn't need to be operated during the night times. It does not increase perforation rates or infectious complications. So is this question now answered based on this non-observative, non-randomized study? Is there a knowledge gap? There is no randomized controlled studies available. So there's an obvious bias here. That the sicker patients will be operated quicker and less sicker patients will be operated later, which will, of course, lead to a conclusion that waiting until 24 hours is safe. And this cannot be completely fixed by statistical means. So, in order to bridge this knowledge gap to get really high quality evidence, we had one question in mind. Will quicker, let's say under 8-hour, appendectomy lead to less appendiceal perforations than scheduled appendectomy within 24 hours in patients with presumed appendicitis? Presumed uncomplicated appendicitis, because we know that if it's perforated already, it should be operated urgently. So we choose methods, randomized controlled study. It's the only one which can really provide definitive answers to this question. And then we did power calculations for this. So we hypothesized that longer delay will not increase perforation rate more than 5%. It's a non-inferiority margin. So we need 1,800 patients for this, quite a lot of patients. So it's not possible to do in a single center. So we had 2 centers from Finland, 1 from Norway, Oslo, and we published this in Lancet in this year, saying that there's no difference between the groups in perforated appendicitis. Both groups had 8%, 9% perforation rate. There is no difference in complications, and there is no difference in surgical site infections. So I provide you a very easy flow chart how to choose a study type. So you ask the question, is it possible to randomize? If it is, do a randomized control study. It's simple as that. But then there are occasions when not to do an RCT. And these are, for example, rare conditions or events. You will have a sample size problems. This is, for example, a rare tumor or a combination of tumors, for example, pancreatic neuroendocrine tumors or rare liver metastasis. You will never get enough patients for those types of trials. A very rare outcome, death after surgery, is fortunately very rare. So it's very difficult to study such interventions that will decrease the mortality after surgery. And very strict inclusion-exclusion criteria. It should be very pragmatic so that almost all patients with a condition could enter the trial. Unethical, this is something that comes up every once in a while, that someone says that this is unethical to randomize patients to these interventions, but this is very rarely an issue actually. It's only for conditions that have a clear evidence that there is, from epidemiological studies, that there is a huge effect size and a dose-dependent responses. I mean, for example, examples are hip replacement for osteoarthritis pain, or adrenaline for anaphylaxis, or insulin for diabetes, or smoking causes cancer. I mean, these are clear that it's unethical to randomize anyone for anaphylaxis to receive placebo adrenaline, because we kind of know without randomized control trial that it's effective. Another thing is that if you don't have a baseline data available, so you might want to do a retrospective study to provide you with a hypothesis or a baseline data to plan your future randomized control study. Also, the question needs to be highly important if you're going to do a randomized control trial. So the results, no matter what they are, need to change current clinical practice. And they need to be clinically meaningful, and they need to be important for the patients as well. There's no reason to study something that is not important for the patients. Let's say whether this intervention decreases operating room time by 5 minutes. It's not very important question. Then you should consider also if there's a compliance problems anticipated. So are the surgeons willing to randomize these patients, and are the patients willing to be randomized for these interventions? There are many trials now and previously being published, like an open versus robotic surgery, for example. The time starts to be so that those trials tend to be very difficult to conduct anymore, because the surgeons will want to do them one way or the other, and it's very, very difficult to persuade the surgeons to randomize to these approaches, for example. And then there's the effect size. If it's very minimal, you will need huge sample sizes, and it's probably not that important question. For example, a death rate after minor surgery. So it's very low already, so you will not get a big difference no matter what you do. Here's an example of baseline or hypothesis generating retrospective study that we did. This is published in 2016 in Scandinavian Journal of Surgery. This is a laparoscopic versus open surgery for adhesive small bowel obstruction. And here we had a 50 propensity score matched patients, and we reported that there is less complications in the laparoscopic group versus open group, and the length of stay was 4 days less in laparoscopy than open group. So pretty much favoring the laparoscopic approach in this small bowel obstruction. So based on this, we designed a randomized controlled study comparing laparoscopy to open surgery for small bowel obstruction, and published it in Lancet Gastroenterology and Hepatology in 2019. We had 100 randomized patients here, and as you can see here, the severe complications in this randomized control trial, it was similar between the groups. So it was not favoring the laparoscopic approach. And if you look at the length of stay, it's just 1 day difference there. It's not 4 days. So based on these results, I would still say that open surgery is still justifiable in these patients, although you can do it laparoscopically. It might benefit the patients, but quite little, just 1 day difference in length of stay. There are also bad reasons not to do an RCT. RCTs are difficult to conduct, but as shown in the picture here, you will do all the work in planning that and then in executing the study, and the writing is very easy. It's the most easy manuscript to write after a randomized control study has been conducted, because you have done all the work. You have planned everything that you're going to report already beforehand. Whereas if you do a retro study without a proper plan, you might have an easy start on going downhill, but then you will need to climb up again when you are writing. Then there's this need of papers for PhD theses. At least in my country, usually 3 or 4 papers are needed for PhD theses. And I find this a little bit problematic, because the science should be, or the PhD students should be encouraged to do impactful science instead of lots of papers. So if there is anyone from the Faculty of Medicine here, so please note that please encourage your PhD students to do impactful research over quantity of papers. And there's also kind of need for papers for your CV for future positions to be the head of the department or the chief of surgery or a professor. And it should not be about quantity of your papers, how many papers you have published. You should, if there's anyone recruiting for those positions, I think you should be looking at top 5, top 10 papers or research projects that that person has accomplished during his or her career, and that should be much more bigger reason to hire that person or not. And this is not really my idea or even a fresh idea. This is a very old idea. This is a famous editorial by Doug Altman in 1994 in BMJ, where he stated that we need less research, better research, and research done for the right reasons. And he said that abandoning using the number of publications as a measure of ability would be a start. This is 30 years ago. The BMJ, Richard Smith, a BMJ editor, published another editorial, Medical Research, still a scandal, in 2014, and he said there, sadly, the BMJ could publish this editorial almost unchanged again this week. So this was 10 years ago. Has anything happened since? I just did a quick look at the PubMed, wrote surgery in the search field, and look what come up. So this is the number of publications that has the keyword surgery in it. There's 2.2 million publications within 10 years. And you can see that there is an increase within this time period of 50%. But if you make a filter with randomized controlled trials, you will see that there is no increase in randomized controlled trials globally in surgical research. And it's a very minor proportion of all surgical research are randomized controlled trials. And those are the ones that actually make the changes in clinical practice. This is a recent paper in BJS analyzing the 2 decades of surgical randomized controlled trial, how the worldwide trends in volume and methodological quality. And you can see here that it has slightly increased from 1999, but in the most recent years there has been no increase in surgical randomized controlled trials. And if you look at the quality, okay, the quality is increasing, but still only 22% of the RCTs are high quality. So a lot of room for improvement here. If we look at the top 10 by relative volume of surgical RCTs per 10 million inhabitants, we see that the Nordic countries are very well positioned in this rank. We can be very happy about this, but I think there is still room for improvement within our countries as well. That being said, I have read many excellent randomized controlled trials published in very good journals within the last couple of years. So I just want to congratulate you that you are doing a high quality randomized controlled trials here. So if you can do an RCT and you are doing a retrospective study, how to make it the best possible. First of all, there's the single versus multi-center versus registry study. So I suggest always going for the multi-center if possible. You will get a larger sample size, you will increase generalizability, and you will get diverse care pathways, and this will reduce some biases that are in the retrospective series. And you do have excellent registries in Sweden, maybe the best in the world. So those are really a goldmine for the research. There should be always some kind of a balancing methods because the retrospective studies are prone to biases. Multivariable analysis, regression analysis are very simple. Usually they are not enough. Then you have the propensity score matching and inverse probability with treatment weighting, which I will talk you in a moment. But what you should do is that you should have a research question that hasn't or can't be studied by a randomized controlled trials. And there are many such questions available there. So you just need to be asking the right questions that cannot be answered by RCT and use your retrospective or prospective registries for that. Just a couple of words about propensity score matching. So if you're not familiar with this method, you will use a logistic regression analysis to have a probabilities of treatment for two groups, and then you match those. So some say that this is like a virtual randomized controlled trial, but I'm trying to say you it is not. So for example, here you will match the patient by their age, sex, sizes of liver metastasis, HSA score, TN, and synchronous or metachronous of the tumor. So this example is chemotherapy versus surgery for colorectal liver metastasis, for example. So the propensity score will take these variables into account, but you will see that this is just the tip of the iceberg. Below the sea level, you have the known but not collected confounders, the variables that you know will affect, but you just don't have it in your registry, or you cannot collect them from your patient chart. But also there are unknown confounders that you are not even aware of that they will affect the outcome, and there is no way of measuring them. Let's say some genetic alterations in your patients that you don't know about genes, we don't know about the genes at the moment, but they still affect the outcome. So the propensity score will only take the visible tip of the iceberg, but randomized controlled trial will also take into account and balance these factors that we don't even know about. The other thing with propensity score matching is that you are not involving or taking into your cohort all the patients that are there. You will just have the matched cohorts, and then you will leave out a lot of patients that have received one or two of the treatments. And if you look at the more detail on the matching, so if you would match here for sex, age, country, marital status, household, socioeconomic status, you would have these two patients here, both males, both born in 1948, raised in the UK, married twice, lives in a castle, healthy and famous, and it's a great match. But if you look at the patients, it's not really the same, to be honest, even though they were a perfect match in the propensity score matching. The other way of matching the patients is inverse probability treatment weighting. And this has a possibility to take the full cohort into your analysis. And it weights the patients so that, let's say that we have a surgery as a reference. So if the surgery is less probable, the patients will have more weight. And if it's more probable, they will have less weight. The upside is that you can have full cohorts in these analyses. It will create a pseudo cohort that you can take in the analysis. But there's a word of caution here. It's not appropriate to include patients that are not candidates for surgery, for example. So if the patients have unresectable liver metastasis, it's not really okay to take them into the cohort. I will go to the prediction models then. And the thing here is that we all want to make a prediction model that is used in clinical practice. But it's very, very difficult to do a prediction model that is going to be used in clinics. So if you're doing a prediction model study, you need to ask these questions first. Is the outcome clinically very important? If you're trying to predict the death, it's very important. But I've seen many papers that try to predict pleural fluid after a specific type of surgery. And that's not really clinically very important thing. You should see if there are many models already done. Usually there is hundreds or thousands of prediction models which no one is using. So you should consider externally validating or updating these models instead of creating a completely new one that no one is going to use. Is the outcome frequent enough to be predicted? For example, again, a death after minor surgery is very unpredictable. It's very rare, so probably it cannot be predicted with high accuracy. And is the outcome possible to predict by the data you have? Sometimes some events are quite random and you don't have all the data to really predict those events. And there are many prediction model potential pitfalls which you should take into account. Small cohort size is one common one. Always do sample size calculations before. There's usually missing data. You should describe and mention how that missing data is handled. Usually it's not okay to just exclude those patients. You should include them and use an imputation to provide those missing values if possible. Many prediction models dichotomize the predictors. Let's say age, they put it there in a less or more than 60 years old. You lose a lot of power if you do that kind of a dichotomization. So please use continuous variables instead. Many prediction models that have been published have no calibration at all. You should always provide a calibration curve. Many use Hosmer-Lehmann test just to show if it's fit or not. It's not okay to use that. There's no model rationale. Many use just a univariable analysis to select the variables for their model. That's not enough. You should have also some kind of a clinical rationale why you include those parameters in your prediction model, and preferably based on the literature also. And then there's the validation problem. Many prediction models just are developed within one center and internally validated in the same center. You should always have an external validation with preferably a geographically different location to really show that your prediction model works outside your own hospital. And then there's the problem that why these are not adapted for clinical use. So it's a leaking pipe model. You have a huge amount of prediction models in the beginning, but then the first thing is that it's not fit for purpose. It was developed on the wrong patient population, it's expensive, or you have variables that are not available clinically. The next thing is that it's not validated at all externally. The third thing is that there's no implementation studies going on, so it leads that the prediction model is not being used at all. It's scientific literature, but it's not routine clinical practice. And the last drop there, dropping into the glass, is the prediction models that are actually in clinical use. I just give you an example of a pipeline for prediction model, and this is a pretty long pipeline. This is a adult appendicitis score, which was developed in Helsinki University Hospital back in 2014. So it's a prediction model to predict whether the patient has an appendicitis or not, instead of routinely imaging every single patient with right lower quadrant pain. So it was developed in 2014. The validation and implementation within our hospital and different hospitals in southern Finland was done in 2017. But it really hasn't gained a large, wide adoption worldwide, even though we see it works pretty nicely. So for that reason, we have designed a Prosecco trial, which was commenced last year. And we randomized there patients with suspected appendicitis to 3 groups. So one group is routine imaging, the other one is adult appendicitis score-based selective imaging, and the third one is actually adult appendicitis score based selective imaging, and then observation only for those patients that are at low risk of having complicated appendicitis. So this is kind of a combination of selective imaging and then a conservative treatment of appendicitis for the ones that have very low risk of getting a complicated one. So this is comments now. This will take a couple of years to complete, but after that, if this trial is positive for the prediction model, maybe it will gain more wide adoption in the future. So now we get to the surgery manual dexterity part, the writing part of the manuscript process. And as Frank Spencer said, this is 25% of good surgery. I would say that this is also 25% of manuscript preparation is just writing. In bjsacademy.com, there's a short BJS course, how to write a clinical paper. So anyone interested in that should see this. I cannot cover everything in my talk today here. So if you're interested, go to the bjsacademy.com and see the course for yourself. However, I will give you some tips and tricks for your manuscript writing. And many people have this, they have a blank page in front of them, and it's very difficult to start writing. Usually the methods and results part are relatively straightforward because you have already done them in the study plan, I hope. But the introduction and discussion parts might be a little bit harder, how to start and how to structure your introduction and discussion parts of the manuscript. So this is just one tip how to do it. It's a modular approach for these chapters. And it actually borrows some paradigms from movie screenplay. This is a Sid Field screenplay book, which is a step-by-step guide from concept to a finished script for movie writing. And it's a 3-act structure. There's a setup, there's a confrontation, and then there's the resolution. And almost, if you look at the movies, so almost every movie follows this 3-act structure. One of my favorite movies is Interstellar. If you haven't seen this, this contains some spoilers, so close your ears if you haven't seen this film. But first, the Act 1 setup. So there's a severe ecological collapse on Earth. There's a need to find a new habitable planet. Then the Act 2, the confrontation. There are many scientists that have been sent to different planets to find out whether they are inhabitable. So Dr. Mann's planet, Dr. Mann sends this signal that his planet is habitable, and the Cooper goes there only to find out that Dr. Mann has actually faked all the data about the habitability in a desperate move to get him rescued from that planet. And then there's the Act 3, the resolution, where Coop finds a solution to send a message to Earth about the gravity to allow humans to exit Earth in the very end. So if you take this 3-act structure and use it for introduction writing, so the first act or first paragraph is the setup. Here you shortly introduce the relevant background and you can give the reader the context to your research. Then there's the paragraph 2, the confrontation. So you will introduce the problem or the unknown subject, unknown on the subject that you are researching. So introducing the missing piece. And then there's the paragraph 3, the resolution. And here you will exactly tell that you will find a solution for the problem that you just introduced in the previous paragraph. I will go slightly in detail with these paragraphs. So the first paragraph, the setup, the goal here is to warm up the reader. You will start with appropriate levels of detail, and this depends on the journal and the topic and the audience of your study. So if you're writing to a pancreatic surgery journal, you don't start up with introducing what a pancreatic organ is. And also you should avoid epidemiological incidence and prevalence figures. Many introduction chapter starts with that the pancreatic cancer is the 4th deadliest cancer in the United States. is your study about the incidence of pancreatic cancer? If it's not, then don't start with the incidence. You can start with more appropriate level for your study. So here's an example. This is Mobile 2 randomized controlled trial from our group. And this is the setup part, so 25%. This is the whole introduction chapter here. So it doesn't need to be very long. I tend to use it. I tend to keep it really short usually. So here it's just shortly introduces that colorectal surgery carries a significant risk of morbidity driven by the anastomotic leakages, and it's unclear how the oral antibiotics work in reducing this risk. The paragraph 2 is the confrontation. So here you make the knowledge gap or the problem visible. And here you need to really know the literature. You need to familiarize yourself very well what is known on the subject. You need to know the most important studies. You need to know what is the unknown or what is the clinical problem here. And you need to tune this paragraph so that your study will answer the unknown or the problem or find a solution to the problem introduced here. And I usually tend to keep it quite short and don't introduce any problems or gaps that you're not going to answer in your study. It will just confuse the reader. So here again, Mobile 2, introduction, confrontation is about 50%. And here we say, for example, that the need of RCTs to focus on specific type and location of colorectal resections, such as rectal resections, were also highlighted by a recent Cochrane review, giving us a reason to conduct this randomized controlled trial. And the last paragraph of introduction, 3, resolution, and you will tell the reader what the study is about and state the aims of the study. It's usually very short, just 1 to 3 sentences maximum. So this is the Mobile 2 resolution part, and we're saying that because of variable practice and lack of high-quality evidence regarding oral antibiotics in rectal surgery, we designed and carried out Mobile 2 trial. So this 3-act structure works also for discussion. So you can have the paragraph 1, the setup. So this is, you summarize your key findings here. Paragraph 2 is the confrontation again. You discuss your findings in the context of current literature. Stuck. Okay. And then you have the paragraph 3, which is the resolution part. This is how your study should affect clinical practice and future research. So the discussion, the paragraph 1, the setup. The goal here is that the reader can read just this paragraph and get the main result of your article. Use plain language and summarize your findings, as this is the most read part of your manuscript after abstract. And make sure that this paragraph is understandable on its own, so it doesn't have much of abbreviations, so that the reader is very easy to understand this paragraph. And don't repeat the aims or methods or introduction here. Just summarize the main findings. Again, the same paper here, the setup. We say here that the mechanical oral antibiotic bowel preparation resulted in less overall postoperative complications than mechanical bowel preparation alone. And that's it basically. The paragraph 2, the confrontation, actually has 2 goals here. So the goal number 1 is to compare your study to existing ones and show the reader how this extends knowledge compared to other studies that are out there. You don't have to repeat the introduction. You have to go deeper here and kind of reflect your study results on other studies that are out there. But avoid exhaustive literature review. You have to keep it short. You cannot put all the studies there. You need to include the most important ones. And I would avoid mentioning and speculating on every minor detail of your study. Sometimes the peer reviewers ask to add discussion about this and that, and sometimes you have to do it. But I would stick to the main outcomes here mostly. The goal number 2 is the limitations that you always have to have in your paper. No matter how strong it is, you always have to have the limitations there. So be honest, be inclusive. There are always limitations, no matter how good your study is. And don't try to hide them, because editors and referees will find out and they will get frustrated. But you can explain how you have tried to overcome or mitigate these limitations. For example, you have done an adjusted analysis, you have done some sensitivity analysis or something, and you can say that, okay, this is a limitations, but we did this sensitivity analysis and the results stayed the same. You may also state some of the strengths of your study. So this is the confrontation part of the discussion. So first there's the goal 1, comparison to the literature, then goal 2, the limitations. And for example, here we say that the subgroup analyses were relatively small and may suffer from false negative findings, that is type 2 errors. Then there's the paragraph 3, the resolution part. And this is the goal is to tell the reader what this study means for clinical practice, or if it doesn't change practice, where should the research field go next? And be very specific here. It's not just okay that more research is warranted. Tell the reader what kind of research should be done. If this is a hypothesis generating retrospective study, say that, okay, this needs to be studied in a large randomized controlled trial in the future. But do not overinterpret your findings here. If it's a small retrospective study, it rarely changes clinical practice, but if it's a large multicenter RCT, it might just do that. So here, again, the discussion and the last resolution part, basically we just say here that mechanical and oral antibiotic bowel preparation should be recommended for patients. Short as that. And now we have done the pre-writing and the writing. So now it's the post-writing, the post-operative phase of the patient. And what Spencer didn't know back then was the enhanced recovery after surgery. So this came only in the 90s and 20s. So the post-writing is equivalent to the post-operative surgical care. You have your manuscript ready, and now you start thinking where to submit this. But how to choose which journal to submit your manuscript? There are general medical journals like Lancet, NAME, JAMA. Then there are general surgical journals like JAMA Surgery, BJS, BJS Open, Annals of Surgery, Scandinavian Journal of Surgery, and then there are specialty surgical journals like European Journal of Vascular Endovascular Surgery, Journal of Bone and Joint Surgery, Neurosurgery, and so forth. So if you have a very large impact study that will affect, is very effective in clinical practice and it's of general interest, you might want to go to the general medical journals. Whereas if you have a small study with very niche topic that's only relevant for your own specialty, you might want to go to the specialty surgical journals. You might have noticed that most of the journals are either based in Europe or in the United States. And this is, of course, something that you might want to take into consideration on where you submit. If it's something that is only relevant for European audience, probably the US journals are not that interested in the study, whereas the European ones might be. And then you might also want to see who is the publisher of these journals. So there are big publishers like Elsevier, Walter Kluwer, Lippincott, Wiley, for example. And then there are Oxford University Press, who is the publisher of BJS and BJS Open, and Sage, who is the publisher of Scandinavian Journal of Surgery. NAME and JAMA and Journal of Bone and Joint Surgery are kind of their own publishers in this sense. And you might want to look at your own university deals, what kind of deals you have with these publishers. Are you able to publish open access free, or do you need to pay it from your research grants? And are the journals open to wide audience, or are they behind paywalls for most of the universities? These differ between the publishers. For example, BJS and BJS Open are owned by BJS Foundation, which is a charity, and it has a deal with the Oxford University Press that publishes the journals, which is, by the way, actually also a charity. Then you have the impact factor, and I'm just saying that these are the impact factors of selected surgical journals, but these can mislead you actually. Just remind you that it's a private company, Kirurgveckan, who calculates the impact factor, and it's calculated so that its total citations in articles published in 2023 to articles published the 2 previous years, divided by the number of articles in that journal published in those 2 years. So it's a mean number of citations per article in that journal. So that means that citations to individual articles can vary hugely. And impact factor of a journal cannot be used to assess whether an article is good or not, or whether an individual researcher is high quality researcher or not. And it should not be used in grant or position evaluation, what is the impact factor of these journals that someone is publishing in. And I just give you an example here. I don't know whether you have heard of this journal, a cancer journal for clinicians. But this is the journal that has the highest impact factor of all. It's 503 at the moment. And Lancet has something like 98. New England Journal of Medicine has 96, but this has 500. And if you look at what this journal is about, it only publishes 65 articles a year. And if you look at the top citing articles here, you will see that those drive most of the impact factor for this journal. And they are all cancer statistics globally and from the United States. And you can imagine that every single introduction chapter starting with that pancreatic cancer is the 4th deadliest cancer in the United States is citing this journal. And that's why the Global Cancer Statistics paper has 12,000, almost 13,000 citations to that single article. And that drives up the impact factor. Now, if you get a publication in this journal, it probably does not tell whether you're a very good scientist or not. And then, so this is a list how to choose where to submit. You want to have reach and visibility for your study. Lancet name gives you excellent visibility. They have millions of readers. I mean, name has 1 million weekly readers, but it's very difficult to publish in those journals. You might want to consider whether it's a USA or European-based journal. US-based journals tend to publish more US-based articles and vice versa. Whether this is because the authors submit more from the United States to the United States journals, or is it because the editors want more US-based stuff there? I don't know. Then you might want to see that whether the journal is a for-profit or whether it's a non-profit journal or a charity journal. This is, of course, value-based decision, and you might not care about that at all. Impact factor should not be a main focus on where you are submitting. It often, of course, goes hand in hand with journal quality, but beware, it's not always the case. You might also want to look at the readership of the journal. Society-backed or society-owned journals often are subscribed by the society members, so the society members read them. This is, for example, BJS, DZR, Journal of Trauma, and so forth. These are society-backed or owned journals. Sometimes surgical studies are being published in internal medicine journals also, but they are often not read by surgeons accidentally, but only read if they search for literature. And then there's, of course, level of impact of your study. whether you think that it has a general appeal and it should be in a general medical journal, or it has a broad impact on the surgical field when it should be published in general surgical journal, or whether it has only impact within your own specialty when it should be probably more appropriate to a specialty surgical journal. So I will end with this Venn diagram here, how to get published. So you need to have three aspects in your manuscript. You need to ask important questions. The study needs to be well executed with decent methods and sufficient sample size. And it needs to be written in clearly with a neutral tone. If you just have an important question and you write it clearly, but it doesn't have good methods, you will have a trust issue of your manuscript. If it's written clearly, has good methods, but it's not the important question, it will be unimpactful. If it's an important question, it's done well, it has sufficient sample size, but it's not written clearly, it's incomprehensible. So when you get them all three, you will get published in the right journal. Thank you.